Kawita Bapat. So the webinar idea behind this, basically this brilliant mind has the idea to start this program to deliver and discuss some important points which is really helpful for our day-to-day practice. So I'm very privileged to introduce Dr. Kawita Bapat. She's been introduced professionally.
Bus.
Okay, so screen is to you, ma'am.
Okay, I'm just sharing my screen, and today we are having topic is pre-gestational diabetes. Am I right, Pricha?
Yes, ma'am.
Yeah, okay. Okay. So this is a basic idea of doing this thing is that we don't want to spend much time over this, what is going on, what not. We'll just fix the small topics and we'll finish it in a half an hour, 20 minutes to 30 minutes. And that's our idea. So it's all glorious journey begins with a bright vision. Now we'll discuss the first case. That's a case 1. M 21 years, presenting at clinic. She is known case of type 1 diabetes mellitus, and for the pre-conceptual counseling she has come. Her HbA1c 7% on metformin 500 milligram twice a day. What had history to be asked, what screening should be done, and what investigation should be done, and what are the correlating consequences. See that this nowadays, with the advance of all these things, the pre-gestational diabetes is also increasing day by day because of the India is also one of the diabetic capital of the world, you can say, and diabetes is also important, and pre-gestational diabetes also taken. So just making things very simple, when an absolute deficiency of insulin, that's a type 1, insulin dependent diabetes mellitus. Then there is an increased peripheral resistance to the insulin, that is a type 2 non-insulin diabetes mellitus. I think I'm clear about it when we talk about type 1 diabetes and type 2 diabetes. Now it occurs is less than 1% women of the childbearing age, but the less than 1% is for this country is also a very big number. And the age of onset and the duration of the diabetes, there is a wide classification, do not correlate with the pregnancy outcome. So it's another very, very important. And for example, if she is having the diabetes right from the age of diagnosed at the age of type 1, diagnosed at the age of 14, and how long she is having the diabetes, but it does not correlate anything with the pregnancy outcome. Same with the type 2 non-insulin dependent diabetes, and what is the outcome. But there are poor prognostic features that include the history of diabetic ketoacidosis, if she is having diabetes ketoacidosis in a previous pregnancy, if she is having a poor compliance of taking medicine and everything, poorly controlled hypertension, that's another one point which this type of patients can have. Then pyelonephritis in the history of this time or the previously also, and while taking the history or counseling prenatal, and the vasculopathy is another important point. So the pregestational diabetes is associated with significant maternal and perinatal mortality and morbidity. That's the worrisome point. And diabetic women should be seen prior to conception. That's a very important point, and she should be, because the pregnancy complications are so much, because they can have the fetal congenital anomalies, they can have the diabetic embryopathy, spontaneous abortion that correlates directly with the degree of diabetic control around the time of conception. So that's very, very important. And the strict glycemic control is important. Now, what is strict glycemic control? It is defined as fasting blood glucose less than 95, 1 hour postprandial less than 140, or 2 hour postprandial, it should be less than 120. So make it a point. Strict glycemic control means all these three things should be there. Approximately 5% of the maternal hemoglobin is glycosylated, bound to glucose, and that fraction is known as hemoglobin A1 or HbA1. So HbA1ac refers to the 80 to 85% of HbA1 that is irreversibly glycosylated as such as more reliable and a reproductive measure. That's why we say we need HbA1ac of 3 months, because it gives almost the idea of 3 months. And it is there. Approximately 5% of the bound to glucose, and fraction is known as hemoglobin HbA1. And it refers, I have already talked about, irreversible glycolysis. It's more reliable and reproductive measurement. And since the red blood cell have the lifespan of 120 days, the HbA1c measurement reflect the degree of glycemic control over the period of 3 to 4 months. So it's another important thing. A normal HbA1c is less than 5.9%. So strict glycemic control is also important, and we should know what is her HbA1c. Now, this is the case too. 31-year-old primary gravida, pregnancy test positive, sugar all well controlled, sonography is 12 weeks pregnancy. How would you plan the antenatal care? And what is she's already on the insulin, body mass index is 10 to 23, blood pressure normal, and there is no relevant medical past history. And there is a strong family history of type 2 diabetes, and both parents are diabetic. How to manage this type of patient? Now, while having this type of patient, what is the aim of antepartum management? Number one, to maintain the strict glycemic control throughout the gestation. As already being defined, fasting blood sugar less than 95, 1 hour postprandial less than 140, 2 hour postprandial less than 120. So a diabetic diet is recommended. While I was reading about it, so what is diabetic diet? It says we need 36 kilocalorie per kg of the body. For example, if the patient is 50 kg, so 50 multiplied by is 36, that will be answered that she'll need the calories throughout. And or if in a pound, that is a 15 kilocalorie per pound of the ideal body weight. Plus 100 kilocalorie per trimester is given. So for example, it comes, if the multiplication comes like sometimes 1000 or 1200, 100 is added as that. Because 40 to 50% carbohydrate, 20% protein, and 30 to 40% fat. Almost all pregestational diabetes will also require pharmacologic therapy, particularly those with a type 1 diabetes. So make it sure if the patient is type 1 diabetes, means insulin dependent, it should be continued like that. The diabetic diet is also very important and should make the strict glycemic control is also important. Now, insulin remains a gold standard for the women with a pregestational diabetes. If the diabetes is being known before and the insulin is this, although oral hypoglycemic drugs, like we give, this is glyburide or glyprazide, not in our, we don't use it, but these are the drugs, appear to be safe, effective, and are being used more commonly as the first line agents. So make it a point that these are the another points. They are not recommended for the women with pregestational diabetes, particularly those type 1 diabetes. So make it a point, the oral hypoglycemic drugs, let's use it during that. Then intense antepartum management and strict glycemic control can reduce the perinatal mortality from 20% to 3.5%. So very, very important. Antepartum management is very, very important. So we have to control this thing. Now, how to manage the antepartum management, what we should do, every 4 to 6 weeks throughout the pregnancy, she should be followed up. Fetal testing is recommended in all cases of pregestational diabetes after the 32 weeks gestation. Because of the risk of abnormal fetal growth, number one, intrauterine restriction or macrosomia, abnormal amniotic fluid volume, and a fetal demise. It's three things are very important and that we should be followed up as soon as the patient reaches to 32 weeks of gestation. Now, these testing should include daily fetal kick charts, weekly non-stress test with or without sonographic estimation of amniotic fluid volume, and ciliary ultrasound Q3 to 4 weeks for the fetal growth. So we should know about the abnormal fetal growth, we should know about the abnormal amniotic fluid volume, and we should know it's about the fetal demise. So if an elective delivery is planned, it should be prior to 39 weeks of gestation, and ACOG recommends that the fetal lung maturity be documented by amniocentesis prior to delivery using diabetes-specific cutoff. So it's very important. If metabolic control is good, spontaneous labor at the term can be awaited. So again, important point, if the glycemic control is good, if she's having a good diabetic diet, if all the sugar levels and everything are good, they should be spontaneous labor at terms should be awaited. Because of the risk of unexplained fetal demise, women with the pregestational diabetes should be delivered by 39 to 40 weeks. So if you plan the spontaneous labor, it should be 39 to 40 weeks. During labor, the patients are typically starved. Glucose should be therefore administered 5% dextrose IV and 75 to 100 milliliters per hour. And blood glucose checked every 1 to 2 hours. Regular insulin is given as needed, either subcutaneous injection or infusion to maintain glucose 100 to 120 milligram per day. During the first 48 hours post-hour, women have the honeymoon period during which their insulin requirement decreased. But we should be very careful during this time also, and blood glucose levels of 150 to 200 can be tolerated during this period. And the once this woman is able to eat, she can be placed back on a regular insulin regime. So these are the simple algorithms, what we are supposed to do when we know that the patient of pregestational diabetes mellitus is there. Then is the patient pregnant? No or yes? Then no, if she's not pregnant, then encourage strict glycemic control, check HbA1c, manage comorbid conditions she cannot be having. She may be having hypertension or obesity. It should be taken care of. And routine preconception counseling, that's a prenatal vitamins, folic acid supplementation, talk about the avoiding the alcohol and all those things are there. But if she is pregnant on that visit, then check early ultrasound to confirm dating, exclude multiple pregnancy and document the fetal well-being. Check baseline HbA1c measurement and check baseline liver and renal function test, 24-hour urine analysis, protein estimation, and creatine clearance. So it's very, very clear if pregnant and if not pregnant. If not pregnant, then we should know about the glycemic control and HbA1c. But if she comes to the pregnancy and she is having this a first visit, it's our responsibility to get the baseline liver and renal function along with HbA1c and ultrasound. Then it's antepartum management, regular prenatal visits, 1 to 2 weeks for the glycemic control as needed, strict glucose control throughout gestation, serial HbA1c measurements, and the fetal anatomic survey is 18 to 20 weeks. Fetal echocardiogram is 20 weeks, and maternal EKG. So another important point and should be added in our list, that maternal echo and a cardiology consultation if EKG is abnormal. So maternal EKG is also important. Then examination of the eyes of the mother. That's because we know there may be chances of any other thing in the retina, that should be there. And weekly fetal testing after 32 weeks. So there can be two chances. Either the patient will have a poor glycemic control or very good glycemic control. If poor glycemic control and a poor compliance, consider delivery at 36 weeks with a mature lung indices. So very, very important. But if the good glycemic control, check estimated fetal weight at 37 to 38 weeks, and we can divide into 3 groups. If the weight is less than 4 kg, await spontaneous labor at term, deliver by 39 to 40 weeks, and that's all. If the fetal weight is 4 kg and 4.5 kg, discuss the risk of shoulder dystocia and resultant neurologic injuries, offer elective cesarean delivery before labor. And if the weight is more than 4.5 kg, recommend elective cesarean section, that's all. And during intrapartum management, again, as we have already discussed, strict intrapartum glucose control, continuous fetal heart rate monitoring, and routine postpartum care. So I think it's very, very clear. If the patient of pregestational diabetes come, yes or no, we know if she's coming for the counseling, then what counseling should be done. If she come into the pregnancy, what's our responsibility as a prenatal visit, and what the antepartum management is very important. But maternal EKG, fetal echo, and the maternal eye examination and fetal vesicle testing is another important. And same if the poor glycemic control, what to be done, and if the good glycemic control, what has to be done, and the weight of the baby at the 37-38 weeks sonographically, it's very, very important. And intrapartum management is another thing, so important thing. So thank you so much for the patient listening, and I think that's a important subject to be discussed on. So I'm stopping the share.